You're watching CTOM TV. Knowledge is power.
Hi, Kay.
Hi.
Hi.
I have been taking targeted therapy, osimertinib.
Oh, wonderful. Okay.
Yes. However, I've had resurgence.
Okay.
I didn't find out I had lung cancer until last year, March 2020. Had no symptoms whatsoever.
Okay.
They actually, by mistake, found it in the brain, which is metastasized, obviously. Anyway, I have got, what's it called?
EGFR.
EGFR,
mutations, yeah.
18 and 21, which is a bit unusual, I believe.
Okay.
And the osimertinib they put me on worked. However, there has been a resurgence now.
Okay.
So I have had during this time radiation,
Okay.
and now they've sent another biopsy away. I had this time a bronchoscopy, yuck, and it's going to Boston, I believe. I mean, we are in New Zealand, so a long way away. So had the first test through the lung biopsy originally, and that was when it came up with the EGFR. Now, the one thing that I am going to ask that I've never heard of in this country is this blood test that you have. What countries have that, and are we able to send my blood there?
We have it. There's a lot of liquid biopsies out there. The difference between most liquid biopsies is they're used for discovering new mutations, like the T790M. They're not used for monitoring old mutations. So because of that, we've developed our own liquid biopsy, and I'm in the liquid biopsy lab here right now. And we have a process that we've used for about 3 years now that isolates the exosomes and then looks at the amount of DNA in them and gives you a relative amount. So we could send you a few tubes and you could use our liquid biopsy. The tubes preserve the blood for weeks at room temperature, which is a new advance. And this is the reason we can do these tests anywhere in the world. And yeah, we can monitor that. Now, in regards to your recurrence, whereabouts is your recurrence? Is it in the lung?
Yes.
Okay.
So I'm under two oncologists. One is the drugs guy, and he's great. And the other one is the radiation oncologist.
Okay, yes.
And he said when he targeted the primary, and by the way, I was a non-smoker, total non-smoker.
Yeah, EGFR, that's common.
Actually.
Yes.
He thinks he may have missed a couple of cells at the very top of the primary, which is a bugger. But anyway, so he's going to target that at a later date. But my brain, one of them is gone. It's only by 1 mil, but they start on that on Tuesday, and I've got 5. It's called SB, where they target in just on the one spot, with a beam.
Good. Yeah.
Yeah. So it's not the whole brain.
Okay, good.
Thank God.
Yes.
Now the other thing is that the doctor has said, the oncologist chemical guy has said when he gets the news back from Boston, which is the Medical Foundation, I think.
Foundation Medicine.
Foundation 1. Yeah, Foundation 1. Yeah. It's tumor DNA sequencing. Excellent test. Was it blood or was it biopsy?
Can't get that done in Australia or here, so it's going to Boston.
Yeah.
And they went in on this Friday, and got it from the Hyla.
Okay.
The Hyla node.
Okay.
So fingers crossed. But he did mention about doubling the osimertinib. I've not heard of that before. That was just the last time I was in with him.
Okay. Okay.
But he said there's another thing that's available now that's just come out.
Yes.
And I can't remember the name, but he said it's absolutely brilliant for your cancer as well.
Yes.
But at
Yes.
65,000 a week, well, no, that ain't going to happen. But I guess AstraZeneca will cap it at some stage,
Yes.
hopefully sooner rather than later.
Right. Right. So a few questions. Do you have the T790M mutation? Do you know?
I'm looking through my records here and I can't find that.
Okay.
I've had a lot of PET.
Okay.
Every 3 months I've had
Okay.
a PET CT. It's quite readily available in Auckland.
Great.
And
Wonderful.
I have an MRI every
Okay.
3 months as well by
Okay.
a particular, what's that there? What's that word? SABR. Oh, no, that's the radiation.
Okay.
So I've had a lot of stuff going on for
Okay.
a while.
Okay. So here's the deal. You've had this metastasis to the brain. That's probably going to be well targeted.
And
radiation.
the spine.
Okay. So radiation is really effective at targeting metastasis to the brain from lung cancers, especially in EGFR positive lung cancers. Now, what the doctors are thinking is that they will see a new mutation, runaway mutation in your new metastatic deposit. And that's why they've sent that sample to Foundation One. Unfortunately, what we usually see in metastatic returns in your subtype, and we did list a bunch of different things, the different recurrence mutations. When we went over EGFR, do you recall we looked over the types of things that cause a resistance?
Yeah.
So they'll be looking at those, and hopefully one of those will pop up. But the chances are you won't see anything there. Chances are you will likely have an overexpression change. And therefore, you want to use a completely different test. You want to use the expression test that is available that will look at overexpression of the genes in the new tumor and see whether it's an NTRK or an ALK or one of these other genes that is causing the change, or whether it's overexpression of a different gene other than EGFR that can be then for targeted in the new tumor. It's unlikely that you'll find a new mutation, but if you do, then that would be great. But yeah, so I think that's the important thing is you need to be looking at overexpression of the 20,000 different genes in the new tumor.
Would you double the Tagrisso? Would you double it?
Would you double the Tagrisso or not?
I would give it a shot. Yeah. Yeah.
Okay.
Yeah. I would look at seeing if you can combine it with something else too.
Okay. So you can combine?
Yeah. Yeah, you can.
I mean, I'm sure Richard knows this, but
yeah, there's tons of different studies on that. Yeah. So, but yeah, see if doubling it works. But I suspect it's going to be a different mutation that's causing the problem. And or sorry, not a different mutation, but a different alteration. And I assume it's going to be expression. It might be a gene mutation that we mentioned, but in order to determine, you've got to get the expression testing.
Michelle, is that the blood test or?
No, it's not blood. It's from a tumor.
Oh.
We need to use tumor tissue. Yeah, it's RNA. We look at the RNA.
Now, what about the blood testing? Would that help you?
Would the blood testing help as well?
Yes. So what your doctors should have done, I don't like to say should have done because they're doing an excellent result. They're doing an excellent thing right now. When you have a emergence of a lung tumor, you want to use the Foundation One liquid, which is a blood-based test. And then you want to save any tumor sample for RNA expression testing.
Mm-hmm. Having said that, working
on the administrative side of coordinating these tests, oftentimes pathology labs don't send all the tissue they have, so they're very likely it is still some tissue at the pathology lab at the hospital where you had your surgery for the removal. And additionally, Foundation Medicine and other genetic testing companies usually don't use the whole sample they're sent, and they do return what they don't use back to the pathology lab. So if you'd like our assistance with that, we can really just make a call on your behalf to the pathologist, find out what they've got, and then assist with coordinating that RNA test.
Oh, great, because you're closer to where they are than I am.
Oh, yeah, time-wise, definitely, yeah.
Would they send it on to him?
And would they send it on to you, or?
As we would need to get you to just sign a form to give us permission to access that, and then that's right, yes. So we can follow up via email, Kay, and discuss what your needs are and how we can help.
Should we discuss this with our oncologist as well?
Of course.
Oh, of course, yeah. Yeah.
Absolutely.
It's all right, it's just Kay's husband here asking questions.
Yeah,
Excellent.
not a problem.
It's good to have support.
Hi.
Hi. It's good for you both to hear this and to be on the same page about your next steps and what makes the most sense. So we're happy to speak to you
and
further.
as that lady was saying before, she's been through so much, and I understand that.
Yes.
And I sometimes you don't take it all in when you're the patient.
No.
You take a lot in, and then all of a sudden you think, what happened?
Yeah.
So
Oh,
I
yeah.
didn't ask the other one.
You get stuck on one thing and miss. Yeah, it's a lot. There's a lot of important stuff happening, and it's very stressful. So it's hard to pay attention. That's why we have all this written down for you to take away as well.
Yes, because when I got told only a week ago about the resurgent, I think my brain went into multitask. I was like, all over the show.
It's traumatic news.
Yes.
It was, because I didn't expect it, like I'm quite, active, and jeepers gave me a real shock. So
Yeah.
I'm now starting again.
Yeah.
He has mentioned the
Katrina.
my oncologist about Keytruda, which is that
Pembrolizumab. Yeah.
yes.
Yeah.
Australia seems to be very at the forefront with immunotherapy. Is that correct?
Yeah. So one of the problems is there is a counteractive pathway in EGFR positive lung cancers that doesn't use the PD-1 system. So chances are pembrolizumab is not going to work for you in EGFR positive lung cancers. However, if we do a expression testing and we see you have high levels of SLA4, then we can determine whether ipilimumab will benefit you, which is the other immune therapy. And we can also look at whether you have a high expression of your PD-1 genes and so on. So, we can look at a variety of different things. We can look at expression of the receptors and genes on your tumors and determine a variety of different options. But I'm going to assume that there's going to be some other targeted options for you.
Thank you for watching CTOME TV. Subscribe below and stay informed.